Okay, let's get back. I originally had a module listed in the syllabus, module 23 or something, and I didn't have it. So this is the Wilkins chapter, chapter 38, which was not in the syllabus, but it's got the same information in it. So we're just going to plow through this. Typically what we do is we'd have an instrument sharpening seminar as well. I've put this off until next semester, but you do need to know a little bit about sharpening prior to when we start this. So we're going over this now. And instrument sharpening is either something you love or you hate. And I did not like it for a long time. But once I realized that I had to do it like I was taught, and there was a reason for it, I started liking sharpening instruments, because once you get used to a sharp instrument, oh my gosh, it's hard to go back to using dull instruments. Some hygienists will be sharpening all the time and some will never sharpen. So if you're sharing your instruments with other hygienists that you're working with, it can be very difficult. The only cat fight I've ever had, and it wasn't really a cat fight, was in an office where I was the third hygienist in sharing our instruments. And one of the gals was trying to explain to me that a Columbia 1314 or a Barnhart, let's say, a universal curette is chapter 38, Ari. It has two blades and I was sharpening both blades and she was trying to tell me it only had one. And I'm going, okay. So we marched off to the employer and said, okay, we need our own instruments. And luckily the employer said, sure, no problem. And that was the end of that. But we need to appreciate the sharpness of our instruments. They have a lot of different instruments out there now. Your technology for the Hugh Freedy instruments that you have is called EverSharp, and they maintain their cutting edge much longer than the standard instrument. And they also have instruments that never need sharpening. Those are more disposable instruments, okay, because you can't sharpen them or you'll ruin them. And so when they do get dull, because they will, you need to turn them in for replacements, that type of thing. So there's a lot of different technology out there, but the whole thing is when you've got instruments that need to be sharpened, it's important that you sharpen them before they get too dull. Because if they get too dull, you are injuring the patient, you're working yourself too hard, and it's very difficult to get a sharp cutting edge and cutting blade on that after they're too dull. So there are different types, okay, of instruments. You need to know what instrument you are looking at and the parts of an instrument. Does it have one cutting edge? Does it have two cutting edges? There are manual sharpening stones where you're doing the movement for the stone. And then there are electronic or electric sharpening stones. I was again in one office where luckily we had our own instruments and she got one of these things out from underneath the counter in the lab because it was an electric sharpening device. And she did not know what the terminal shank was. She was supposed to line something up to get it parallel to do, and she was doing it wrong and she ruined every instrument she had. So you have to know what you're doing with these, because if you sharpen incorrectly, you are creating a dull instrument. You are creating a situation where you have to manipulate your wrist in certain ways to make that blade engage. So this is what a dull curette looks like, okay? Why do I know this is a curette and not a scaler?
Because it has a semicircular cross section.
Yeah, semicircular cross section. All right, now when you've got a sharp cutting edge, all right, it's going to appear like a black line if you're looking at it with light, but if you've got a dull cutting edge, it's going to reflect light. That's what that picture is supposed to be. But you want to keep sterilized stones available, and you have 2 sets of stones that are in your kit. And when you get your second year kit next year, you will have a different type of sharpening. It's called a card. It looks like a little credit card, and it's metal. So we'll give you experience in the different types of manual sharpeners there are out there. But you want to keep them sterilized because sometimes you're in the middle of treatment and you need to sharpen your instrument. Okay, because these instruments don't stay sharp sometimes during an entire scaling, root planing, root debridement session. So you want to always have something available to use your side. Is it ideal to sharpen chair side? No, the patient doesn't want to hear you. They don't want to hear that, nor do you want to take the time away from treating the patient to sharpen your instruments. So you want to make sure that you've got a stone ready in case you need it. If you're in the middle of treatment, you need that sterile stone. Preparation of the sharpening stone. What type of stone is it? Can you use it dry? Do you need to use water or oil on the stone? And that depends on the type of stone that you have. So there are certain tests for sharpness. And again, we're going to go over this next semester, but this is just the overview. The visual or the glare test. Remember that, where is it? This is the visual or the glare test here. Okay, does it have a shiny surface or is it a nice black line? Okay, that black line shows that it's sharp. There's also plastic testing sticks, which you have in your sharpening kits. They're blue. And you can use that to see if there's a bite. Confirming sharpness, also using the plastic test stick, you want one sterile with your sharpening stone in case you have to do something chair side, right? That way you're using the plastic testing stick to test if it's sharp and not something that is going to dull the instrument. In my day, we used our thumbnail because we weren't wearing gloves anyway. So why not shave off your thumbnail? I'll shoot you if I ever see that. And then the evaluation technique. So we're going to get into a little bit of this time. Now, this is what the blue sharpening stick is like. They used to not be autoclavable. They used to be clear. We used to put them in cold sterile, the quote unquote magic blue water. But what you're doing with this is you're placing the blade against this sharpening stick as if this is the tooth, okay? And then your working angle, which is what, like 70 to 80 degrees, and you're just seeing if this bites. You're not trying to shave off plastic. You're just trying to see if it bites into that. When you're done sharpening, you want to make sure that the instrument is wiped. Okay, if you're going back in the mouth, you're going to wipe the instrument, of course. You want to make sure that you're always ending your stroke in a downstroke. Sometimes you get these tiny little wire edges, okay, these little spicules of wire, and you want to get those off before you autoclave or go back into the patient's mouth. But instruments, every time you sharpen, you are narrowing the face of that blade. Okay, the lateral surfaces, you're narrowing it. So the instrument's getting thinner and thinner. Now, right now, you've got brand new instruments and they are shovels when you're trying to get them underneath some tight tissue. They're just too big. You sharpen, you sharpen, you sharpen, and if you're working every day or whatever, after a month or so, they're perfect because they're a little bit narrower. You can get in where you need to go, and you're still sharpening and sharpening, and then all of a sudden they get too narrow. and they're useless. So a lot of us will have instruments that they cycle through. I usually have a new instrument and an older one that's on my tray. So I will have a new one. Okay, that's great for heavy calculus and that type of stuff. I'll have one that's just right that I've been sharpening for a couple of months. And I'll continue to sharpen both. By the time my one that was perfect is getting too thin and needs to be cycled out, the new one from a couple months ago is now perfect, and I put a new one in, and I'm always cycling through that way. I am spoiled in that I get to use the instruments and have what I want. But that's how I've learned to take care of it. And the longer I teach, the more particular I am. But when you sharpen, you've got these tiny little metal spurs or burrs that you want to make sure you wipe off. You don't want those metal burrs impregnating into the sulcus or the lining of the gum tissue. Because when you're sharpening, you are removing metal. So let's take a look at sharpening. Okay, you want to first examine the edge that needs to be sharpened. You want to review the angulation of that needs to be restored. Is it universal? Where is that terminal shank compared to the face of the blade? And then you want to stabilize and position the instrument. So depending on if you're moving the stone or moving the instrument. And the technique over the years, my friends, has not changed, but the verbalization of how they're explaining it has. When I was in school, this was the angle that we learned, 110. This is the angle that you're learning, 70 to 80. Okay, so the stone is at a 70 to 80 degree angle, all right? This is at a 110 degree angle. 90 degrees is straight up and down. So you are going to be holding the instrument stationary, okay, and look at this hand. It is stabilized against something that is non-movable, like the tabletop. You're moving the stone and you're going around, moving the stone. There are other ways to sharpen. We are going to be teaching you how to move the stone, and we'll show you other ways as well. Or you can hold the stone stationary and you move the instrument. So again, there's different ways of doing it, and we'll show you both ways. Everybody sharpens a little bit differently. I like doing the moving, it depends on how dull the instrument is. I use both techniques, moving the stone or moving the instrument. The file scaler, remember that file? There is something called, okay, a tanged file, and you sharpen each one of those separately. I have never, ever sharpened a file scaler, ever. But just know that it's called a tanged file. The sharpening equipment, okay, you are removing metal. So that metal gets on the stone, and you have to make sure that you are cleaning that stone properly. So you want to remove the metal from the stone, and you want to autoclave that stone. Sometimes they're wrapped in a gauze. Sometimes you have to lubricate the stone before it goes into the autoclave. Depends on what type of stone you're using. Okay, and that's all I need you to know about the care and feeding of your instruments. The question is, do we need to do the Navigate quiz for this chapter? No, you don't need to do a Navigate quiz.
Would this chapter might be included on the exam, or it was just a review?
There are going to be basic questions on sharpening on the exam, yes.
Okay.
Yeah. And at the beginning of next semester, we will go over that. And we will have dull instruments that are actually shipped from Hugh Freedy to have you play with, because we don't want you ruining your good instruments that don't need sharpening yet. Okay, so hold on here.
Misty, so have you decided what chapters are going to be on the next exam?
Yeah, but I don't know what they are. It's everything that we've had so far, area specific especially. Okay, this is, if I can share this, hold on.
We have one more exam before the final, right?
Yes, we do. And the final's comprehensive. So I want to get us caught up on everything. And so that way the final really is just a review.
Okay, so even the next exam is going to be kind of comprehensive? Or is it just going to be on a certain few chapters? Like
Just a few chapters.
just a few, okay.
Do we know yet which Wilkins chapters yet, Misty?
Everything that we've had up to today,
Okay.
up through today, yeah. And I'm
From the
trying-
last exam.
from the last exam,
Yeah,
yeah.
I think it's chapters 16, 21, 25, and 37, and then a little bit of the couple you said we were going to do about sharpening.
Well, then that would be 38, 30, wait, 16, 21, 25.
Oh, wait, unless we did 16 on our last exam, because I actually think I have that written down for our last exam.
I don't have my paper in front of me. What was chapter 16?
Chapter 16 was hard tissue examination. I think that was on our last one, wasn't it? Or no?
No, we didn't have that. We did, I think we did 17 and 19.
Okay, so then chapter 16, 21, 25, 37, and 38.
16, 21, 25, 37, and 38. That sounds right.
Yeah.
And that's enough for a test, isn't it?
Yes.
Well, I'm just glad that the beginning part of the semester is over. That is pure HE double hockey sticks for everybody with all the information that you have to cram into your poor little heads. Okay, this isn't anything you're going to be tested on. This is just something that we're going to go over. Okay, fictitious patient cases. Periodontal debridement, this is a review. The removal of bacterial plaque biofilms and calculus deposits from the crown and or root surfaces within the pocket space, right? Because of the structure of biofilms, physical removal of bacterial plaque biofilm is an effective mechanism of control. So this is, yes, we're going to do this in Gehrig, okay? The information is still there. So we want to deplaque patients. That's one reason why we were using this ultrasonic technology. We were deplaquing. Okay, we were flushing out all that bacteria and we were educating the patient. We're going to use this automatic scaler and it's going to remove a lot of that bacteria and flush it out of the pocket, you know, because we can't do that as effectively with our hand instruments. Well, unfortunately, because we were ultrasonicking almost every patient that was coming through the office. Now with COVID, we are not, and hygienists are really salty because they have to go back to this physical removal by hand instrumentation. But calculus removal is a critical step of any non-surgical periodontal therapy because calculus deposits always, and you know there are very few alwayses when you're being tested, but always harbor living bacteria biofilm. We want to reestablish periodontal health. We want those root surfaces to be as free of biofilm and calculus deposits as possible. Now, this says we need to remove all calculus deposits. Studies have shown we never remove all calculus deposits. Even the best of us, we're leaving a huge amount of calculus behind. So let's review. Again, this is a review. Traditional root planing involves the intentional removal of cementum. That's how I was taught. You're instrumenting all the root surfaces until they are glassy smooth, because remember that cementum is rough. It had periodontal ligaments embedded in it at one point, okay? Then the thought was to remove that retained bacterial products held in the cemental surfaces, which in theory is correct. But if you're removing all the cementum and making everything glass-like smooth, there is nothing, those desmosomes and hemidesmosomes, there's nothing to help create that long junctional epithelium. So scaling is the instrumentation of the crown and root surface of the teeth to remove plaque biofilm, calculus, and stains. Versus root planing is the treatment designed to remove cementum or surface dentin that is rough and contains impregnated calculus. Now, those are the traditional terminologies. When I started teaching back in the mid 80s, there was a whole shift in how things were being taught, because there was a shift in the technology and what we found out about what causes periodontal disease. So we found out that vigorous root planing not only is not universally needed to reestablish periodontal health. This was sacrilegious to a lot of the periohygienists, but the bacterial products can be removed with minimal amount of actual cementum removal. Goes against everything we were taught. So there is something called periodontal debridement or debridement, and that is the removal or disruption of bacterial plaque biofilm, its byproducts, and calculus deposits from the crown and roots of the teeth. Do you see the difference? We're not purposely removing cementum. We're not purposely making the cementum glass-like smooth, but what we want to do is remove those harmful products. We're also, okay, those are your working strokes, we're also deplaquing. Deplaquing is the disruption or removal of subgingival microbial plaque biofilm and its byproducts from cemental surfaces and the pocket space. So periodontal debridement encompasses both of those, and that's why we are so in love with the ultrasonic scalers, the magno-restrictive and the piezo-restrictive. It deplaques beautifully for us and flushes things out. You will be learning how to do this with your hand instruments. That's your walking, 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 walking. Oh, it's a little bit rough. I'm going to increase my lateral pressure, smooth, 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 walkie, 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 walkie. Okay, you are deplaquing every surface of that tooth underneath the gum tissue. You're not using walking strokes. I'm sorry, working strokes. So for periodontal maintenance, you've had the patient in and you've done the root debridement, and now you're trying to maintain them every 3 months or whatever their recare dictates. And that's the continuing patient care provided by the dental team. That's you. The goal is to prevent recurrence of disease. Now, is that primary, secondary, or tertiary prevention? Think back, my friends. This is a final exam question. Primary prevention is to prevent the occurrence of disease to begin with. So you're healthy, you want to stay healthy. Secondary prevention is you have some disease, and you've reversed it or you've stabilized it, that's secondary prevention. And tertiary prevention is those needing surgery to regain function. So is this primary, secondary, or tertiary? The goal is to prevent recurrence of disease.
Secondary.
Secondary, exactly. It's also board questions. You're never going to get away from that. You also want to assist the patient in maintaining periodontal health by following completed surgical or non-surgical therapy. So we're always emphasizing the need for continuing care as well as follow through with the treatment plan. So we need to be communicating with our patients. We, as dental hygienists, provide the patients, okay, what education they need to place value on the care that we are recommending for them. A lot of patients don't have the same oral health values that we do, but the value a patient perceives may be influenced by the way the services are referred to by the hygienist. Are you coming in for a checkup? It's time for you to come in for your checkup. Or it's time for you to come in for your periodontal maintenance therapy visit. I mean, however your office or your continuing care visit or whatever your office uses, all right? It's not just a checkup, all right? The hygienist's goal is to convey information in a clear, easily understandable method that will build trust. And again, we want to show the patient and inform the patient what we're doing. We're taking blood pressure. Why? We are doing an oral cancer screening on everybody. Why? Okay, and that we are trained and educated in order to do this. We're not just a technician here to clean the calculus and stain off your teeth and send you on the way. We are treating the whole body. So the words that we use are really important. Mental images are created by words. Scale versus root plane may create negative images versus tooth cleaning, prophy, checkup are going to minimize what we're really doing for the patient. So we want to educate them in terminology. Gum disease versus active infection. You've got a little bit of bleeding here. Versus you have an infection in your gum tissues on this lower right area. You have infection, it's bleeding. What is going to make the patient stand up and listen to you more? Using the word disease may be more frightening to the patient versus infection, but adults understand that infection is serious and needs to be treated. They might not understand disease. So many diseases, everything's got a disease oriented to it now, all right? So it is an active infection. If any other part of your body was infected, you would want to treat it. So we need to be able to use everyday words to help the patient understand what they have and what we are trying to do and how they will benefit from it. That's where this informed consent is all about. You want the patient to understand the intent and significance of the periodontal instrumentation. We're not calling it a deep scaling. Patients, you know, are you going to do a deep scaling? Well, and I always, from the time I graduated, said, well, I'm going down to the base of the pocket. It might be down to your toes or, you know, wherever it is. Oh, well, I was told I had to go to the periodontist because I needed a deep scaling and they're special. They do more than you do. And I said, look, we went to the same schools and we took the same board exams. They don't, you know, how are you presenting this to your patient? And I'm going to try and stay off my soapbox, but we need to be able to tell the patient what they need. People have the right to full disclosure of all relevant information so they can make informed choices about their care. And an informed choice is always, no, I don't want it. So part of that is cost. They need to know how much it's going to cost. They need to know how much time it's going to be involved. They need to know what the prediction is, what their prognosis is. And they need to know what will happen if they say no. you could end up, the disease process could continue to the point where you will lose your tooth. Okay, now will it? I don't know. Have no idea. So the dental hygienist provides complete and comprehensive information about the recommended plan for periodontal instrumentation. That's one of our primary jobs that your employer is going to want you to do. That is one of our primary things that hygienists and dentists get sued over, is lack of informed consent, lack of diagnosis. Patients need to make well-informed decisions about accepting or rejecting proposed treatment. And if they haven't been told they have infection and disease and bone loss, they don't know. They've been going to you every 6 months, but if nobody's mentioned and you're just billing a 1110, an adult prophy, and not talking to them about disease, they think they're healthy. The insurance companies are saying, you are saying it's healthy by what you've been submitting to them. So there's some ethical considerations for informed consent. And you're going to get into more of this as in your capstone of ethics and jurisprudence, but you need to let the patient know what is expected from successful outcomes. What are some of the risks involved? Possible unexpected results, and what alternative approaches to treatment can there be? All of that is part of informed consent. That is part of presenting your treatment plan for all patients. What are some of the possible consequences of refusal of treatment? Cost, the patient's capacity to consent, their age, their mental status, their IQ, dental IQ. Are you explaining it and how they can understand it? And again, the written consent by the patient. So all of our patients sign their treatment plan consent that they are consenting to. It's been explained to me, and I am accepting treatment. I am accepting that I need to come here 6 times. I am accepting that I may need local anesthetic. I am, accepting this responsibility so you, the student, can get your quality points. So capacity for consent. What is the patient's ability to fully understand the proposed treatment, the possible risks, anticipated outcomes, and alternative treatments? What is the patient's capacity? And we're not just talking mental capacity, it's a language capacity also, especially in Northern Virginia. We have so many patients coming from every area of the world that communication can really be a barrier. So we need that two-way communication between the patient and the hygienist to get good informed consent. And sometimes we need a family member of the patients to help translate for us. So that's the written consent. The patient's going to sign it. Sometimes the husband will sign it for the wife. We are documenting that things were explained and translated by husband, by wife, by sister, by whatever, and signed by, okay, if somebody else is signing, especially if it's a caregiver. Verbal and implied consent is not as legally binding as a written consent. So we want signatures. There's something called informed refusal. I don't want x-rays. I don't want fluoride. I don't want, just give me a regular prophy. You're going to have these patients. Some offices will have an informed refusal form. It has been explained to me why I need these radiographs. It's been explained to me that what might be missed if I don't have these radiographs. And it's been explained to me that there might be a misdiagnosis based on the lack of these radiographs. And then they're signing the informed refusal. It just makes them think a little bit stronger about this refusal. Is it really binding? No. If you needed an x-ray in order to, or a radiograph in order to properly diagnose a certain situation, that dentist is still legally responsible for making a proper diagnosis. So what dentists are doing, hopefully with their risk management courses that they're taking, is, okay, I'll let it slide this time, but next time you need to be prepared to have radiographs taken, or we're not the office for you. I'm sorry, we're going to miss you. You've been with me for 25 years. However, we need to take a look every now and then. And isn't it great if nothing's changed? But we don't know. So we need to really be mindful of how we're explaining things to patients. And this is where what we call your OHE, your patient education book, that you're going to be making next semester. Yes, you've got to make this book. And it's going to be something that you can go through with your patient, not only about oral hygiene, but it's, what is gum disease? What are cavities? What causes this? What are you doing here in the clinic? And why are we requesting certain procedures like radiographs? Why are we taking blood pressure? Why are we doing an oral cancer exam? That type of thing. So you're going to be classifying patients. You're going to be seeing lots of things. You're going to have to determine how many visits is it going to take. Now, when you're a novice student, it's going to take multiple visits. When you're out in private practice, can you do something in one visit, or are you going to need multiple visits? It depends on how that patient is presenting in the chair. Can you do a sextant at a time, a quadrant at a time, 2 quadrants at a time? How much can you complete? And this is where we as faculty will help you when you start seeing patients, because you don't know. You're a novice student. You think you could do 2 quadrants, and we're going, well, let's do it 1 tooth at a time. And then you're going to get upset with us. But guess what? You've done 2 teeth and it took you an hour to do those teeth. You're going to, whew, boy, this is taking longer than I thought. So let's take a look at some of this historical perspective. We're going to get into this a little bit more also in your DNH 146. But years ago, what we did was we did something called gross scaling. And then we did fine scaling. Offices are still doing that. The first scaling appointment was we went through with the ultrasonic and we got off as much as we could just with the ultrasonic, and we left calculus there, subgingival especially. And then the second appointment we spent removing the medium-sized deposits. This sometimes we did it all in one visit. As far as the first visit was the gross scale, the second visit was the fine scale, or we brought them back for what we considered, and I'm using air quotes, scaling and root planing, but we did the whole mouth each and every time. We went through the whole mouth, and that's called circuit scaling. And that was, we were removing calculus, and then we'd come back, we'd remove more calculus, then they'd come back and we'd remove more calculus, and we were whittling away at each appointment. This is how we used to do our hygiene. The problem with that is incomplete scaling is not recommended, because what you're doing is you're leaving behind deposits that are rough. Those deposits are always covered with biofilm. That tissue, when you take off that heavy calculus, that tissue is then going to tighten, closing the pocket. Okay, the edge of that marginal gingiva is going to be nice and closed, because that's where your ultrasonic was really able to reach. And that can lead to abscess formation, that periodontal abscess or gingival abscess formation, leaving calculus behind. And once that pocket closes off around that gingival margin, it's more difficult to get an instrument in there. Insertion is more difficult because the tissue is tighter. You have decreased patient motivation, because guess what? You've gotten all that supragingival calculus off. They feel clean, but you've already done the cleaning. You've gone around all my mouth. So the patients feel very frustrated when they see you going back over and over and over the same teeth all over again. So it requires explaining to the patient, I'm going to deplaque all the areas of your mouth with my ultrasonic, and you're not removing calculus, but you're just trying to deplaque. And then I'm going to concentrate on, this quadrant, and then I'm going to concentrate on that quadrant, but you're deplaquing at each and every appointment. Your goal is not to remove supragingival calculus. So now the goal of each appointment is to decide how many teeth you can complete for calculus removal. You only start what you can complete, be it one tooth, several teeth, a sextant, or a quadrant. You can complete, if you can complete 2 quadrants, you complete the quadrants on the same side of the mouth. You don't want to do the maxillary arch and then have them come back and do the mandibular arch. You want the right side and then the left side, and we'll get into that, but you want to do quadrants on the same side. Okay, gives the patient a side to chew on. It divides the work up evenly too, because one quadrant, one arch is going to be heavier than the other arch. Okay, so it's dividing that up equally too. And if you need local anesthesia, you cannot do anesthesia on the mandibular arch. You can't do 2 blocks. You can infiltrate, which we'll learn about later, but it's better to do one side and then the other. So appointment planning. Okay, we've gone over the process of care. You are only going to complete what you can start, what you can complete. So you need to take things into consideration. How much deposit? How long is it going to take? How much surface area do I have to clean? Do they have a lot of root surface or very little amount of root surface? They could still be a difficult patient, but if they don't have the landscaping of deep pockets, it's not going to take you as long to scale as if they have all sorts of cementum that's exposed. Okay, so let's take a look. We finally get into some pictures. Ooh, what is this called, ladies and gentlemen? It's recession.
Is it a fissure?
Nope. If there's recession, so this is the gingival margin. The probe is going to go down to here. And this is the mucogingival line. If you've got 1 millimeter or less of attachment, what's it called? Mucogingival defect. Know that term, mucogingival defect, because that's going to also be on your 111. Mucogingival defect. This one's created because of recession. Okay, but let's see here. This is still patient number 1, all right? You've got a mucogingival defect because the gum tissue should be about here, all right? Lack of attachment. Do you see a lot of calculus? A lot of inflammation? This is supragingival calculus here, adjacent to the Stenson's duct. Again, adjacent to the Stenson's duct. But the tissue overall looks pretty healthy, doesn't it? You'd be able to do more with this patient. This is sometimes, I don't want to say a typical recare patient, but this is what you're going to be seeing a lot of. This is a standard patient. What would you do to help the patient not get this? That type of deposit that's right adjacent to Stenson's duct. This is where a power brush can really come in handy. Is the patient flossing? When I see calculus here, that patient is probably making too big of a stroke back and forth instead of the little wiggles. When we get into toothbrushing technique, you just want tiny little wiggles to allow that brush to shimmy around the nooks and crannies of the teeth. Mandibular. What's that? That is calculus, if you haven't seen calculus. That's supragingival calculus. They don't have pocketing. They've got nice attachment down here. But guess what? Are they even brushing the linguals of those teeth? We don't know. We're going to have to see what they're doing. They need OHI really bad, oral hygiene instruction. Their periodontal charting. Their probing isn't too bad. They've got some gingival overgrowth. They've got, their probe depths. They've got some 4 millimeters, which is consistent with some gingival inflammation. So not bad. Versus you have this patient coming into the chair. Think about how would you calculate the CAL, all right? You've got your gingival recession. So you'd be charting the GM, right? Then you're charting from the gingival margin to the mucogingival line. And do you add or subtract these for your CAL?
Add them.
You add them. Exactly. You're going to have CALs until you die. That's what we live by. Your CAL. So you're checking to see where that gingival margin is. And they've got a lot of this patient, probably, this is a gold foil restoration. This is an amalgam at the same area. So this looks like somebody's probably been to a dental school. Looking at that. Looks like an older individual. All right. This looks very fibrotic here, but can you see the outline of the glossiness? That's probably a pocket going all the way down to the junctional, going right down to here.
I have a quick question too. Is that rolled gingiva?
Yes, this here, this is rolled or blunted papilla. And you would be classifying not only the shape of the papilla, but you'd be classifying the interdental space. So this is a type 1, 2, or 3 papilla. That's a type 2. It almost fills in the embrasure space versus the mandibular anterior is a type 3, completely open embrasure space. So if you've got anything more than a type 2 or type 1 embrasure space, this patient might be saying they're flossing every day, but this patient is wasting their time with floss. That's not the best use of their time. There are other gadgets, the water flosser, the water pick, or a Proxibrush. Let's get a brush in here that can get into those root surfaces that are exposed and get those concavities, because the floss is not going to reach that. And we're going to get into all of these techniques next semester.
Misty, for people with this heavy recession, is there like any, what do you call it? Like, can they go back to normal?
Never, without surgery.
Oh.
Never.
So with the surgery, like they put, like what they do, like they put something instead of the gum?
Yeah, they can, you have growth factors that you can put in. There's bone augmentation that can be done, so they can actually put things in here to create more bone. Now, will it ever get to be a normal? Probably not. But they can definitely add more bone to add more support. Okay, surgical procedure. And we'll learn more about that when we get into perio next semester.
Okay, but they still need to get like that each month, like each 6 months cleaning.
This patient would be in every 3 months at the most. They might even be coming in every 2 months, depending on what their case is. Their gum tissue doesn't look too bad. I mean, this maxillary arch looks like it's nice and pink. The posterior of the mandibular doesn't look too bad. So if things were stable every 3 months, it could be you need them back every 2 months. You're customizing your treatment for each and every patient, whether or not insurance is going to cover it. And that's where education comes in.
Okay, but it's not making it any more sensitive than it is, right? The
No,
teeth-
if you're not overscaling.
Okay.
If you're not overscaling. Okay, this is the posterior of that same patient. You can see that, you know, they've got a blunted papilla here. Don't know what that's all about. I wonder what the pocketing is. We'll see what the perio is in just a minute. Generalized recession. Look at the perio though. 3s and 4s are for probing depth. So the tissue seems to be pretty tight. Okay, not the tissue has shrunk along with the bone. It would be different if your bone level was still, I mean, if your tissue was still up here, the pockets would be reading deeper.
So does this mean that the patient flosses but is lacking in brushing properly?
Or the patient, it's just the way their disease manifested itself. It could be that they've had surgery already, but it looks like they're doing a decent job of brushing. I would want to, with 3s and 4s, what can we do to try and get these 4s into 3s? And it could be that they need the Proxibrush or something else, but are they able to maintain? This would be a power brush, and I'd probably want them using a Sonicare over an Oral-B. Depends on what the patient is presenting with. Like this guy. Would you want to use the ultrasonic on this guy? I'm saying that's the first thing I'd want to do. Let's get the ultrasonic out and buzz all of this biofilm off. But guess what you're doing? All you're doing is all the bacteria that is adhering to these teeth, all of this stuff is just loose.
Would that be a contraindication though? Or
This
no?
would be a contraindication, a big contraindication. You never get your ultrasonic out just like this. You would always do OHI first, oral hygiene instruction. And most of this then would be coming off because you don't want this aerosolized. And look at the color that's on this enamel. You don't know what's going on underneath this biofilm and that heavy materia alba. There could be cavities under there. You don't know. And if you're using a power instrument, you're going to disrupt that and create holes in the tooth. So you always get all that heavy loose stuff off, and you're disclosing, you're showing the patient, and then the patient's demonstrating and you're refining technique. But look at this acute inflammation here. They're going to bleed. They're not going to like you. They're not going to want the brush touching that area.
Would this be a good patient to use a file on, Ms. Day?
No. There might not have that much deposit, hard deposit. This could just be all soft stuff. Depends on what
This really is just from not brushing.
This is from not brushing.
Wow.
This is from, look at this calculus here. This is all calculus. And look at the inflammation. That is acute inflammation. I'm not looking at the schmutz anymore. I'm looking at the bite. How would you classify? Now they're probably doing more of an edge to edge, maybe not, because this patient is, you can see the mamelons here. So this patient hasn't been using those anterior teeth, so they probably do have an open bite. There's a cross bite here. Tendency towards a class 3 because this canine should be right here. That's one side. Look at where the canine is here. This canine is in a class 1 position here. So the right side, this is the right side, and the left side have two different bites. occlusal classifications, which is why you do a molar and a canine occlusal evaluation on each patient. Gingival inflammation. So the patient's exhibiting some 4 millimeters up here and some 5 millimeters, but how much of that is inflammation versus bone loss? It's probably all inflammation. If you get all that soft stuff off and the calculus off, the tissue is going to shrink and hopefully you'll get 3s instead of 5s. Another patient. You'll be seeing something like this almost every day. Tissue doesn't look bad. So when you disclose, you're going to see the biofilm is going to be just circling. So the patient's not brushing effectively on the lingual surfaces. Looks like they're brushing a lot on the facial surfaces because of recession. And the tissue looks better than it does on the lingual. Within normal limits, 2s and 3s. So the bone level is good. Is this a 1 visit, 2 visit, 4 visit? You know, it depends on how much time you're given. If you were dealing with half-hour appointments, this would not be a 1 visit appointment. But in private practice, we would do this in 1 visit. If you're in a perio-oriented private practice, I would do this in 2 visits. You've got infection going on. We need to get the infection under control, is how I would present it. They don't have bone loss, but they have infection. Another patient. Are you seeing the difference in patients that you are going to be getting? What's going on with this tooth here?
That's rotated.
It's rotated. Okay, very good. These are the linguals. Don't you just want to get your instruments out? And that's the bad thing with instructors. We see that and we just can't help ourselves. And you're going to say, but I wanted to do it. Sorry. We have to have fun too. This patient's got pockets. 6 millimeters, 5 millimeters. Look at this, 7 millimeters on the left side. This patient's going to need more root debridement.
Miss D, is that a normal pigmentation?
This is a very normal pigmentation. This is called physiologic pigmentation, and this is just this patient has more melanin. So they're probably a darker skinned. And sometimes you'll see this splotchy. But the nice thing, if you've got this patient in the chair, guess what? You don't have to guess where that mucogingival line is, do you? These are great patients to have in the chair for that mucogingival junction.
I'm curious, on the canine where you have the lighter spot, is that a pocket?
No, that's just a lack of pigmentation here.
Okay. Well, on the top as well. Yeah, it doesn't look.
Yeah, no, that's just the way their melanin pigmentation is.
Okay.
This is very normal. Sometimes you'll see it splotchy. Sometimes you'll see it this nice and dark. There are some cultures also where you'll come in and you'll see it from just on the anterior area and they're tattooed. because that's a sign of beauty from their culture. So sometimes they're tattooed like that. Does anybody know what culture that is? And I'm sorry that I'm not familiar with what region of the world does that. So I ask, you know, especially if it's just in the anterior, I ask. If you don't know. Yeah.
Sorry. On the molars, the white area, what are those?
This could be hypocalcification. It could be some decalcification. It could be mild fluorosis. Don't know. But what you would do is you'd mark them. Ooh, 2s and 3s. They've got a 4 here. Gum tissues don't look too bad. Why do you think there would be a 4 on this probing depth? Look at where the gingival margin is. Okay, and this was on a canine. This gingival margin is really, it's above the height of contour of the tooth. So the gingival margin should really be about here. So there's probably a little bit of gingival overgrowth, or what they call it, passive eruption. Cosmetic dentists would be saying, ooh, you've got a gummy smile. Let's trim this here. And they trim it down. But this patient, the gum tissues don't look too bad. This would be a one visit appointment. So you can see that you're going to be having all sorts of different patients coming through the through your office and through our clinic. And what you're going to have to do is come up with a treatment plan before you even know what you are doing as far as how tenacious is that calculus. But you've done all the assessments. You've taken your radiographs. You've done a complete perio assessment, including your CAL, how much calculus there is, the tenacity of the calculus. Then you're putting together a treatment plan. Can I do a sextant at a time or a quadrant at a time? Can I do 2 quadrants at a time? That type of thing. And we'll be helping you with that. And if you can do 2 quadrants, do you want to do the same side or one arch?
Same side.
Same side. Yay. Thank you, Jody. Same side. That's the takeaway. Only start what you can complete and work on the same side if you can. Okay, and that's what we were going to discuss today.
So Misty, I just have a couple things from the chat box that I didn't want to interrupt you during.
Oh, sure.
So one of the questions was, are you going to email us later with all of the chapters for the exam?
Yes.
And then just to clarify, were there any Gehrigs on the exam?
Yes. Area specific?
Okay.
Predominantly. There will be this on the exam that we went over today, but a lot of it was review. Okay. I will have, Adriana will come in probably on Thursday and take a look at the exam. I'm hoping to have it completed by then, so she'll know specifically what's on it so she can help guide you. Any other questions that I missed?
Filter it from the chat box.
Do we need to do navigate quizzes for this chapter? No, unless you want to. I love the navigate quiz questions only because it just gets you in the habit of looking at those questions. Gehrig, yes, it will be on. I had no question. Oh, I had a question, but forgot it. Okay, Jennifer. Any other questions? Email me if I have an outstanding email, ladies and gentlemen, please, please, please email me again. I do not mean to ignore anybody by any means. So, so you're not harassing me if you send me a reminder email. I appreciate it. I will have extracted teeth tomorrow. If those of you that are going on campus want to take a look at them, remind me. I can get the bags of teeth out as well. And you know what? We're done with the semester. Can you imagine? Can you imagine? Think about all that you've learned. I am in awe of first semester students because in a matter of like 12 to 14 weeks, think about where you started from and where you are. It's truly amazing.
Miss D, I have a quick question.
Yes, Karen RC.
So for the exam number 6 on the schedule, it also says that we're gonna review for the final exam. Are we gonna do that, or is it gonna be recorded?
I haven't decided yet.
Yeah, okay. So I was just asking you because I told you I cannot be here that day. So if they
Oh,
could-
well, if I do have a review, I will definitely record it.
Okay, great,
Yeah.
thank you.
No, I'll record it.
I have one more question.
Yes, Jonathan.
What time are you gonna be in in campus tomorrow? Because I still have to turn in my 2 drawings to you.
Oh, okay. I will be on campus in the morning for sure because I'm in local anesthesia lab, but we're into nitrous, so we're not going to be there. It's going to be an abbreviated session. If I'm not there, give the tooth drawings to Mrs. Heberly and she'll put them in my office.
Okay, thank you.
All right, or to staff and she can bring them back or whatever. But yeah, and I will get them Thursday at lecture.
All right, thank you.
You're welcome. Okay, any other questions?
Misty, I got a silly one. So for the occlusal drawing up to 2, doesn't matter which like which